So good afternoon, everybody, and welcome to the Family Medicine Grand Rounds for today, April 20th. And you can see here listed the activity code for today's session if you are interested in CME credit. I'm going to go over that in a little more detail, but the main thing is to just remember to do that before midnight tonight. You'll want to make sure that you follow the process. So on the next slide here, there are some more instructions. Specifically, if you haven't done so yet, just make sure that you text your email address to the number listed there. And then once you've done that, you'll be registered, and you can then take the activity code for today. You'll send that, you'll text that to the CME office there. So as we begin, we want to thank you for joining us. If you could please make sure that your microphone is muted as we get started. Also, if you could remain attentive and engaged in the session. For today's session, if you would like to put your questions in the chat box, we'll be taking a look at those at the end of the session. And then, of course, I will also put the information, I'll put the link for the evaluation towards the end of the presentation, if you could help us out with that. So this is the South Texas Regional Family Medicine Grand Rounds. We are partnered with the South Central AHEC, and our mission statement is listed there for you to read. CME transcripts are available for those who do claim credit. Just make sure that you check every so often by visiting the CME website. You can view your transcript to make sure that you are getting the credit for the sessions you attend. But if you have any questions, please feel free to reach out to their office, or you can give me a call as well. And also for the AAFP members who would like to claim credit, you will need that CME transcript, but this presentation is acceptable for 1 credit. So please make sure that you do claim that as well if you are a member. But any questions, please contact them, or you can contact me as well. We also want to point out as we begin here that it is our goal of our Grand Rounds presentations to address the nationally established physician core competencies that you see listed there. And we also do need to mention that Dr. Nassar has no financial relationships with ineligible companies to disclose. He is going to be talking to us today about a practical approach to CKD and what does the PCP need to know. So we have Dr. Nassar. He is going to be giving this presentation. He is a clinical associate professor from the Department of Medicine, and I'll let him go ahead and get started.
Hi, everyone. Thank you for this invite. It's my pleasure and honor to be here with you. I've been in this institution for a while, so I probably know a lot of you. Did my residency here and did my fellowship as well. Joined as a faculty 6 years ago, and now I'm the Nephrology Fellowship Program Director. So when I was approached about giving a talk, they asked me to give a talk about CKD. And to be honest with you, my interest in nephrology is mainly in physiology, hyponatremia, channels, and transporters. So it was a little bit tough topic to me because it's a big topic that I need to condense and make sure that I give a clear message and a highlight of what a primary care physician needs to know. Or how do I think as a nephrologist, how would I approach a CKD, and what you guys need to know in that regards. So objective would be understanding the overall approach to patients with chronic kidney disease, emphasize the importance of urinalysis, and we'll go over examples and urine protein creatinine ratio and the workup, implementing an evidence-based intervention to slow the progression of that kidney disease with a focus on ACE inhibitors and ARB and Sgl2 as well. So I'm gonna make this a kind of a simple talk and make it practical. In nephrology, we tend to complicate things. So in order for you guys to understand CKD well, the only thing that you have to remember this slide. There's probably 100 equation here. So if you remember all of these equations, you will understand CKD really well. That was a joke. If you're in a live session, you should be laughing. I'm not gonna put any equations in this talk, and we're gonna take a practical and easy approach of how should we approach CKD. So why do we care about CKD to begin with? around 26 million of Americans are affected, and the prevalence is pretty high. And if you look at the Medicare budget, Medicare spends a lot of money on CKD care, especially ESRD care. 28% of Medicare budget in 2013, up from 6.9%, goes to ESRD and CKD care. And it's very, very costly for the government. So especially, as I said, the ESRD care is very expensive, although it's a small percentage of Medicare population. Medicare spends a lot of money on ESRD patients. Of course, having a CKD can increase the risk of all-cause mortality, kidney failure and other adverse outcome that we'll talk about. And especially here in Texas, if you look at this map here, you can see the incident rate is very, very high in Texas, especially South Texas. And you guys see a lot of patients with diabetes, high blood pressure, a lot of obesity here in San Antonio as well. And unfortunately, all of these are risk factor for CKD and eventually ESRD. And if you look at the trend of annual number of ESRD incident cases by modality, you can see that, for the last 2-3 decades, you can see that there is an increase in the incident rate, especially in hemodialysis. The hope is that if we catch all of these patients early in the process of CKD, and we do things, like blood pressure control and other things we'll talk about, to prevent or at least slow the progression to ESRD, that would flatten the curve or maybe slow down the progression of these patients. So as I said, diabetes and hypertension are the leading causes for kidney failure in the United States. We see a very large amount of patients with diabetes and a large amount of patients with diabetic nephropathy. We see diabetes at a very young age here in San Antonio. Diabetes and high blood pressure remains kind of the most common causes for kidney failure in the United States and CKD. And the rest kind of a mix of GN and hydronephrosis and other causes of CKD, but mainly diabetes and hypertension. So what's the role of PCP in CKD care? I think primary care physicians can really play a significant role, mainly in the early diagnosis, treatment, and patient's education, as well as a timely referral to nephrology. A greater emphasis should be on detecting CKD and managing it prior to the referral, to be honest with you, because we have a huge backlog of CKD patients that we need to see in the clinic. And a lot of time, it might take 3 to 6 months until a patient can see a nephrologist. Low GFR can increase the risk of systemic complications, mortality, progression to ESRD, cardiovascular, hypertension, and other things that we'll talk about. It's very important to screen our patients with high risk, like the patients that you see on day-to-day basis, with diabetes and hypertension for CKD, and implement things that will change the course of CKD and hopefully slow the progression and prevent dialysis. So how do we define CKD to begin with? It's an abnormality of the kidney structure or function that's present for more than 3 months. So the duration is very important. Anything less than 3 months, by definition, it's acute kidney injury. So the main thing we focus on is the eGFR. So decreasing the eGFR more than 3 months below 60 ml per minute is defined as CKD. But even if you have a normal GFR or above 60 ml per minute, you can have CKD. Having a proteinuria or albuminuria itself is CKD, considered to be CKD. Having urine sediments abnormalities, electrolyte abnormalities in the setting of RTA, or things that you see on imaging, cyst, hydronephrosis, or if you have a patient with one kidney, solitary kidney, atrophic kidney due to some certain anomalies when they were born. So it's not only eGFR, it goes beyond that. And in this talk, I really want to emphasize on the urinalysis and the proteinuria, and hopefully I can make some impact in the way we kind of approach patients with CKD and in terms of management. So how do we classify CKD based on the GFR and albuminuria? So we classify it into, sorry for this, we classified it based on the eGFR and the degree of proteinuria. So G1 to G5, G1 is very high or almost normal GFR, and then CKD5 is you have your stage 5 CKD. And then you have A1, A2, A3. This is the degree of proteinuria, normal to mild, moderately increased from 30 to 300, and severely increased more than 300 milligram per gram. And I think, to be honest with you, some of the guidelines suggest that referral to a nephrologist, should happen around CKD4. And to be honest with you, I disagree with that, because I think if you send me a patient's CKD4/5 to my kidney clinic, to be honest with you, I think it's too late in the game and I can't do much for these patients. I think, referral should happen mainly during this stage 3A or at the latest B. But when I see a patient with CKD4, to be honest with you, it's very often that things already happened in the past and the kidney has a lot of fibrosis and most of the damage is irreversible. If you pay attention to the degree of proteinuria, and we'll talk about how do we kind of quantify and look at the proteinuria itself, but severely increased proteinuria here is defined as more than 300 milligram per gram of albuminuria. This is mainly albuminuria. And if you look at our patients' populations, we see 1, 2, 3 grams or even more than that very commonly. And we got used to this kind of high number of kind of proteinuria and albuminuria. When we see 400 and 500 or 600 or anything less than a gram, we kind of say it's a mild or it's not much. But to be honest with you, it is a lot of proteinuria. Our patients' population are very sick, and sometimes they present too late, and that's why I think early referral is really important for management and kind of early diagnosis. So I'm going to present some cases throughout the lecture so that I can kind of make few points in regard to the practical approach. So I have 64-year-old male patients. This is a new patient's visit that comes to the CKD clinic. Past medical history is diabetes and high blood pressure. He was an ex-smoker. These are his medications, and his blood pressure is pretty high. And after I'm gonna present about what we're gonna do for this patient later on, we'll see what happens with the creatinine and with the proteinuria and how we started with this patient's labs and how did we end with different labs. So blood pressure is pretty high. The patient has 2+ edema, and the serum creatinine is 1 milligram per deciliter, which is pretty good. But looking at the UA has 2+ protein, otherwise unremarkable. There's no RBCs, there's nothing else that I can see on urinalysis. So we'll come back to, please remember that the presentation and the blood pressure and the edema and the creatinine of 1 and the urinalysis with 2+ protein. We'll come back to this patient at the end of the lecture. So how would I approach, if somebody kind of come to my clinic, how would I approach this patient in my CKD clinic? Targeted focus history and physical exam is really important, especially the history. When I see a patient like this, I will dig deeper into this history of hypertension and diabetes, and assess for other cardiovascular kind of disease or comorbidities. What's the duration of disease? What's the degree of the control? Did this patient lose to follow-up for many years? This A1C has been in the 10 range for a while. So the duration of the disease and the degree of the control of that disease should be assessed. Mainly when I approach a patient with CKD, what I'm trying to do is actually kind of go over a risk factors that puts these patients into kind of CKD category. Why would this patient have a CKD? I need to have an answer for this. So the presence of multisystemic disease as well. My wife gave a lecture to you guys last week about systemic lupus erythematosus. So patients with rash and joint disease and other things you have to think about autoimmune disease in this process. I always ask about recurrent history of infection, especially pyelonephritis, recurrent history of kidney stones that will put the patients into risk for CKD. Looking at the prior labs and history of patients, recurrent history of AKI will always increase the risk of patients to having CKD. We have, when all of you see patients in the inpatient setting with AKI, and a lot of time, a lot of AKIs recover. But in reality, to be honest with you, it's only a biochemical recovery that happens in AKI, meaning that the serum creatinine kind of goes back to baseline or to a normal range. But what's happening at the tissue level and the histology level is really different. A lot of scarring, a lot of fibrosis that happens. So every AKI happens to the patients, puts the patient at risk of CKD. And if you biopsy these patients, even with normal lab that's resembling their baseline, you're going to find some degree of fibrosis or kidney damage that you don't see on the lab. Assessing of a family history of kidney disease, of course, risk factors for HIV, hepatitis B, and hepatitis C. IV drug use is very common in our patients' population. These, this is the way I approach patients. And I have a template, to be honest with you. I ask all of these questions: and history of AKI, and look at the labs, and history of STDs, IV drug use. And each time the patients kind of give me an information that puts them at risk of, AKI or CKD, that kind of trigger an alarm in my brain that, maybe this is a potential cause. Drug use, NSAID use, very important. Herbal medications. I ask about herbal medications in my history all the time. There is this kind of trend in medicine to take herbal medication to rinse your liver, rinse your kidney, and to kind of cure diseases. And a lot of us know that, these patients or these medications are not FDA approved, are not backed by clinical trial or any evidence. So it's a common question that I ask, do you take anything over the counter, any, medications, any herbal medications? And the amount of medications that the patients take over the counter and these kind of random substances are a really large percentage of patients. They think that, their neighbor or their friend gave them this medication because it's a kidney rinse. And a lot of time it's the opposite. It's a nephrotoxic. This is something that maybe we should focus on a little bit more during the history. Substance abuse, as I said, history of smoking. Long history of smoking puts you at risk of CKD. If you want to dig a little bit more deeper, you can look into the toxic environmental factor, occupational factors that lead to CKD, like chronic lead exposure or heavy metals. Physical exam plays some role, but mainly in the management and kind of assessment of the patients, mainly not to kind of know what's the cause of the CKD. I think I would 90% or 80% of the time, I know the cause of CKD mainly by taking a thorough history and kind of run through this kind of list in my mind and in my notes and assess the degree of kind of comorbidities and what's happening with the patients. So after we take a thorough history and physical exam, I think we have to look at two things. Looking at kidney ultrasound and to look at urinalysis. I can't emphasize enough about the importance of urinalysis in the approach of patients to CKD. My thought process when I look at urinalysis changed 100% when I look at the urinalysis. When I see a bland urinalysis, meaning that there's nothing on the urinalysis, no protein, no blood, everything is negative, versus a patient with protein and hematuria and other things. That will change my thought process 100%. So, and at the same time, also kidney ultrasound is an important tool, and I'll talk about this a little bit deeper. But I think after your history and physical exam, looking at both kidney ultrasound and urinalysis is very important. For example, if we look here at the left side, if we have a patient with normal size kidney, and then we're looking at urinalysis, if there's no protein, no RBCs, this patient doesn't really concern me that much in the kidney clinic. This patient, let's say that the patient comes with the creatinine of 2 and urinalysis is bland. In my thought process, I would think that this is something related to kind of AKI, something happened in the past. There's not an ongoing inflammation or damage that's happening at the kidney level at this time. While if I have a urinalysis with a lot of proteinuria and I look at RBC cast and RBCs, this is a very concerning for me, because I need to worry about GN and lupus and about other things. So really important to look at urinalysis and kidney ultrasound as well. So digging deeper into that urinalysis, it's a very simple, in the kidney clinic, we do a dipstick, and it can be very useful for our patients. And the main focus should be looking at blood and looking at protein. The urinalysis is very sensitive for RBC. So even 1 to 2 RBC can be really detected in urinalysis. Negative protein urinalysis sometimes can be tricky because it doesn't really detect certain protein. It's mainly detect albumin. So a negative urinalysis probably should be confirmed by a UPC, and we'll talk about how do we quantify a proteinuria in these patients and what the numbers mean. But if I get a urinalysis that everything is negative, the blood is negative, the protein is negative, I have a reassurance at this stage that and I have a kidney ultrasound that's normal. Even if I have a creatinine of 2 in my head, there's not an ongoing inflammation that's happening right now in the kidney that I really need to worry too much about it. And I take my time to kind of explore, why does this patient have a CKD? You can look at other things, glucose and ketones and all of that, but the most important 2 factors or 2 things that to look at, blood and protein in the urine. So I'm going to present this case that I saw when I was a first-year fellows 8 years ago. 18-year-old male patients without any past medical history present to the PCP for dark red colored urine. Patient was given antibiotic. They thought he has UTI, and they gave him antibiotic, and went home. Urine culture came back negative, but somehow nothing happened after that. Patient presented again to the urgent care after 1 month with similar symptoms and was given antibiotic again for a possible UTI, despite that the culture was negative the first time. So 2 months later, the patient presents to the hospital with swelling, lower extremity edema, creatinine of 2.2, and we biopsied these patients, and the patient had ANCA vasculitis. So if you take this patient who is 18-year-old, that doesn't have any past medical history, there's no diabetes, there's no hypertension, the patient doesn't have any kind of past medical history, comes to you with a UA that shows 2+ protein and 3+ blood, that should trigger a lot of alarms in your head that I'm dealing with some sort of GN, and I can't explain why the patient has protein or blood in the urine. This is different from your patients who present to you with 20 years of history of diabetes and hypertension and a lot of comorbidities that happens, and having a creatinine of 1.5 or 2 and has some protein in blood. This patient has no past medical history, and he's a young male patient presenting with recurrent UTI, which is not very common in male patients, and he has 2+ blood, 2+ protein and 3+ blood. This patient should have been referred really early to nephrology with the possible diagnosis of kind of GN. So this is really important, emphasizing on urinalysis and looking at both the proteinuria and the hematuria. So how do we assess? I promised you guys I'm not going to give you a lot of equations. I'm going to give a simple kind of calculation here to assess the proteinuria. So how do we assess proteinuria in patients with CKD. As I said, we should not be excreting a lot of proteinuria in normal adults. So it should be around less than 150 milligram per day. That's for proteinuria, including other proteins. I'm not talking about albumin. The degree of excretion of albumin is even less than that. It's going to be around 20 milligram per day. So persistent albumin excretion between 30 and 300 milligram is called moderately increased albuminuria, and persistent albumin excretion above 300 milligram is actually considered to be a severe increased albuminuria or proteinuria. And I don't know why we're still calling it microalbuminuria and macroalbuminuria. This terms, to be honest with you, in our guidelines doesn't exist. So it should be just kind of moderate increased albuminuria or severely increased albuminuria. And that microalbuminuria is kind of tricky. People think that the albumin size is small or something. It has nothing to do with, the albumin size. Is mainly the quantification of the albumin is a little bit less. So what's the best method to assess proteinuria? 24-hour is actually the gold standard of measurement of proteinuria excretion. But it's really cumbersome. A lot of patients don't know how to do it. It's very often incorrect. It's over collected or under collected. So very often as a nephrologist, we depend on urine protein creatinine ratio to assess the degree of proteinuria. And usually you need to look at it in the first or second morning urine sample after avoiding exercise, because illness, acute illness and exercise and other things could actually increase your proteinuria. So when we look at urine protein creatinine ratio, what are we trying to estimate? We're trying to kind of estimate what is the 24-hour urine proteinuria in this situation. So the urine protein creatinine concentration, it's a spot sample measured, when you divide, proteinuria over creatinine concentration, and it gives you a number. That number is an estimate of how much proteinuria this patient's we're going to be excreting in 24 hours. It is a little bit tricky in patients with extreme kind of situations, older patients and cachectic patients, and young patients with a lot of muscle mass. Because if you look at that kind of urine protein creatinine ratio, it's heavily influenced by the urine creatinine concentration in the denominator. And that can actually skew your result a little bit, whether you overestimate or underestimate. But in general, it's a good estimation of how much you estimate in 24-hour collection. So let's take a couple of examples here. So an individual with around a creatinine excretion of 1,000 milligram per day, it's a really good estimate for 24 hours. But if you have a patient with a large muscle mass who really excrete a lot of creatinine, this UPC could actually under or a large number of creatinine excretion. And the opposite, if you have patients with, older patients, cachectic patients, have a small muscle mass in whom creatinine excretion is really low, the amount of proteinuria could be overestimated. But in general, to be honest with you, would it matter if I know if this patient has 3 grams of proteinuria or 4 grams? I think it's a good way of kind of checking if the patient has proteinuria, the degree of proteinuria, and to trend the proteinuria as well, and to see what happens with, after you implement some changes in the medications. So if you get a number, let's say that you're ordering UPC, or it's the same applies for urine albumin and creatinine ratio. If you get a number of UPC of 1, that means, if I do a 24-hour, roughly I'm going to get 1 gram in a 24-hour. If you have a UPC of 2, that means I'm going to roughly get, if I do a 24-hour, I'm going to get 2 grams in a 24 hours. 0.5 means 0.5 grams. So and so on and so on. And the same thing applies for also for urine albumin creatinine ratio. Very important that you should not use UPCR to quantify proteinuria and AKI. In AKI, if you have a patient in the hospital with AKI, the amount of urine creatinine is very low because obviously the patient has AKI, the kidney is not functioning well. So the amount of creatinine in the urine is really slim. So any number, a lot of time UPC could be overestimating the amount of proteinuria in patients with AKI. One time, one of my fellows told me that this patient has 20 grams of proteinuria. And if you look at the urine creatinine is basically nothing. And that's why you get a number that's high. So don't make the mistake in assessing UPCR in patients with AKI. You have to have, the patient has to be in a steady state in order to use the UPCR or UACR to estimate proteinuria or albuminuria. So how would you use ultrasounds in patients with CKD and approach to CKD? So very often we'll take a look at, you see like this kind of increased echogenicity, which a lot of time, to be honest with you, doesn't mean much to me when I see increased echogenicity. It maybe indicates some degree of chronicity, but ultrasound becomes very useful for mainly to recognize advanced irreversible kidney damage that you would see a kidney with 6-7 centimeters, and you see that this is a dead kidney. You can't really do much about this kidney. So there's not much I can do about this kidney. And to be honest with you, the only thing that we can do is actually prepare for dialysis. You can take a look at echogenicity. Of course, you can assess the degree of, if there's hydronephrosis or inner obstruction. But mainly, it's useful for me to look at cyst, look at the size of the kidney. So size and shape, kidney length in adults should be around 10 to 12 centimeters, but varies. There's no really kidney ultrasound based on the body size and weight, but roughly between 10 to 12 centimeters. Echogenicity, increased echogenicity specificity, but it might correlate with some kind of degree of interstitial fibrosis and tubular atrophy. But you can have a normal echogenic kidney and you still have CKD. You assess urinary space for hydronephrosis, obstruction, and looking at masses and cysts. So look at this kidney on the left side. It's normal echogenic kidney, and the size here, although it's not measured here, but it's around 12 centimeters. Looking at the kidney here on the right side, this kidney is actually 6 centimeters. So if I have a patient, you present to the clinic or in the hospital, and I get an ultrasound and I see a 6 centimeters kidney, my next step is to prepare patients for dialysis. I'm not going to do workup. I'm not going to do biopsy. I can't do anything. This kidney, if you biopsy this kidney with 6 centimeters, you're going to find scarring, fibrosis, glomerulosclerosis. You're going to find a lot of chronic changes that you really can't fix, and it's irreversible. So if you get an ultrasound and you have a small size kidney, and I would say probably around 6 to 8, this is pre-advanced kidney disease. So an example, whether you see in this patient in the clinic or you see the patient first time in the hospital, 64-year-old female patients with uncontrolled diabetes and hypertension, who's here for evaluation of CKD with the eGFR of 15. No baseline labs available, patient has not been followed up, doesn't know anything about diabetes and hypertension. You're getting an ultrasound, you see an atrophic kidney, echogenic kidney with a size of 6 centimeters. The discussion for this patient should be mainly focused on kind of dialysis. I can't really fix anything, and I can't promise the patient with anything that I'm going to be able to kind of save patients from dialysis. So it becomes really handy in these situations. So as I said, history is very important, followed by looking at two main things: urinalysis and kidney ultrasound, and assessment of proteinuria. And after that, I will have a targeted focused lab that I do. I don't just kind of, there's some people will have this kind of like CKD evaluation lab, and you have like 100 labs that you order on all of these patients. That I don't take this approach. I do a focused lab based on the patients and the risk factors and what I see. So in general, I do tend to order hepatitis panel and HIV in all of my patients, especially the patients who have proteinuria. If the patient has proteinuria and hematuria, and ANA and C3 and C4 could kind of guide you toward, lupus or other kind of diseases or other GNs. And in older patients, if you have an older patients with anemia or hypercalcemia, we tend to order SPIP and kappa lambda ratio to see if there's a role of kind of multiple myeloma or etiology of multiple myeloma in this CKD. So I don't order a lot of labs routinely like ANCA and double-sided DNA and other things. This is where I kind of start with urinalysis, ultrasound, and hepatitis panel HIV, ANA, C3, C4 for patients with protein hematuria, and SPIP and kappa lambda ratio for older patients, and anemia and hypercalcemia. So when you see these patients, they're going to have a lot of manifestations of CKD, and you're going to have to deal with a lot of things according to the eGFR. So early in the GFR, really nothing happens, but the more progressive the CKD, the more issues that you're going to have. You start to have issues with hyperpara, hyperphosphatemia, and then when you have a patient with CKD4, you're going to have hypocalcemia, anemia, hyperkalemia, acidosis. And then, of course, the later stage of CKD, you're going to have to assist them for uremic symptoms like nausea, vomiting, poor appetite. And this is where we really closely follow the patients every 4 weeks or so to kind of assess if they need dialysis or not. So as I said, to be honest with you, if you send me the patients below a CKD, like CKD4, what probably I will be doing is mainly controlling their hypertension and dealing with their anemia and hyperkalemia and acidosis and things like that. But I think it's too late for me to do much to prevent that CKD progression and to fix what happened for these patients. So early referral is much better for these patients. So how do we manage these patients? The whole idea is to manage patients with CKD is to prevent the progression of CKD to ESRD, or at least slow the progression. A lot of time, to be honest with you, we can't really prevent the progression unless we catch that patients really, really early in the process. And of course, to deal with complications such as AKI and anemia, acidosis, and other things that happen that we talked about. And at the same time, to reduce patient safety hazards, especially from polypharmacy and nephrotoxic. And I have a slide at the end, but I can't really emphasize enough on how important it is to look at the medications and make sure that all of the medications are really dosed, not just because of the nephrotoxicity. It's a lot of them have systemic toxicity because the kidney acts as a filter for a lot of medications along with the liver. And if you have significant degree of kidney damage, you really have to renally adjust and renally dose these medications. So how do we slow the progression? Each patient is a different, you'll take it in a different approach. If you have a patient with GN, you have to treat the GN. If you have patients with hydronephrosis, you have to relieve the obstruction. But in general, we see a lot of patients with diabetic nephropathy who are hypertensive. So I'm going to take the approach of slowing the progression in patients with diabetic nephropathy and hypertensive nephropathy and see what we can do for these patients. So we slow the CKD progression by controlling the blood pressure. The goal should be less than 130/80. You should aim to use angiotensin II converting enzyme and ARBs for these patients, especially for patients with albuminuria and proteinuria and hypertension. We'll talk about the use of Sgl2 inhibitor as well, targeting a hemoglobin A1C of 7%. And then I'll briefly talk about correction of CKD associated acidosis and how that plays a role in the CKD progression. So this is a very common thing that I hear from a lot of physicians, from my patients, from my parents, my friends. So drink at least 8 glasses of water a day. Is there any scientific evidence for 8x8? Would this slow the progression of the CKD? A lot of time in my patients in the CKD clinic, they'll tell me, oh, I'm drinking a lot of water. And I need to drink some water right now to rinse the kidney. And so they want to flush the kidney, they want to rinse the kidney. And in all reality, that doesn't really help at all. The kidney doesn't get really rinsed. When they tell me I want to rinse the kidney and flush the kidney with drinking a lot of water, this would be my reaction. So please don't recommend high water intake for your patients with CKD. Water intake should be guided by thirst. That's why we feel thirsty. We feel thirsty, that means that we need water because of high osmolality. CKD patients do not handle water appropriately. They cannot handle a large amount of water, and a lot of time you can actually ending up having hyponatremia in these patients and running into a problem with kind of admissions and all of that. So water intake should be guided by how thirsty the patient is, and if they're restricting their sodium, they should not be actually feeling a lot of thirst. The only time I would recommend water intake for my patients is actually patients with kidney stones, and is mainly to kind of dilute them sediments and make sure that they don't get kidney stones. But beside that, water intake should be guided by thirst mechanism. So how do we slow the progression? There are a lot of guidelines, and we kind of follow KDICA guideline. So blood pressure control, as I said, there's some debate about like the goal of the blood pressure, with whether you have proteinuria or not proteinuria. But in general, less than 130/80 is acceptable. Use of RAS inhibition and glycemic control. And of course, diet is important, especially sodium restriction, less than 2 grams. It kind of helps the ACE in slowing the progression, better blood pressure control as well. In the recommendation, they still have this kind of protein restriction for CKD patients, but to be honest with you, we don't restrict protein in our patients, especially in patients with advanced kidney disease, because a lot of them actually don't have appetite, and there is a risk of malnutrition in these patients. So I don't do a protein restriction for these patients. As I said in the beginning of the slide or the talk, I love physiology, and my main passion in nephrology is physiology. And I give a lot of talks about hyponatremia and diuretics and all of that. So I'm going to bring a little aspect of physiology into the talk to kind of set the stage to see how we're going to end with that kind of patients that we started with after we do ACE, ARB, Sgl2, and let's see what happens with the creatinine at the end. So this is your GLOM, and this is your normal filtration. You have your afferent. This is the GLOM. So the blood comes from the afferent, goes to the GLOM, and then leaves the GLOM from the efferent. So in patients with diabetes without therapy, there's actually what's called a hyperfiltration. If you look at patients with diabetic nephropathy early in the stages of kidney disease, you'll tend to see actually a 14-15 centimeters kidney, and that might indicate actually there is a lot of hyperfiltration. What happens? You have a dilatation of the afferent arteriole that leads to kind of more pressure in the GLOM, and this increased pressure of the GLOM will lead to hyperfiltration or more filtration. So some of you might say hyperfiltration and the GFR is supranormal. That should be good. It's not good actually. Over the long term, this hyperfiltration can increase the intraglomerular pressure, and that puts a lot of stress on the podocytes and eventually accelerate the kidney disease progression. So I always see in the notes by residents from internal medicine and family medicine and other people that we're doing ACE and ARB or Sgl2 for renal protection. When I ask, how does it protect the kidney? They look at me and it's like, oh, we're not sure. So one of the advice I would give for the residents, always stay curious, always challenge yourself, challenge your attending. I think staying curious, is really important for us to kind of evolve in our education and knowledge. And otherwise, if you don't ask why this happened, what's the mechanism of, renal protection, or any question you have, you would stay stagnant in your medical knowledge. So staying curious is really important, not only as a trainee, even as a physician throughout of your life. I think it's really important to stay curious, and that will stay with you for the rest of your life, and will evolve your medical knowledge a lot, to be honest with you. So how do we protect the kidney? By giving ACE and ARB, and Sgl2. So protection, I'm going to take two slides here. On the left side, I'm giving a patient a RAS inhibition. So as we said, there's a dilatation of afferent arteriole in patients with diabetes, creating a more pressure in the glam. So by giving ACE or ARB, actually what happens, you have a dilatation of the efferent arteriole. Angiotensin II constrict the efferent, and when you constrict the efferent, that even puts more pressure on the glam. So if you dilate this efferent, you relieve the pressure in the glam, and that's why you have a dip in the eGFR or an increase in the creatinine when you start ACE or ARB. Looking at the Sgl2 inhibitors here, you have what happens with Sgl2 inhibitors. Actually, you have afferent arterial dilatation reverses, or there is a constriction of the afferent arteriole. So with the ACE or ARB, you dilate the efferent, that will relieve the pressure, and with the Sgl2, that will constrict with the Sgl2, that will constrict the afferent as well. So both of them will lead to reduction in the intraglomerular pressure. And when that happens, you're going to see an increase in the creatinine, you're going to see a dip in the GFR, but over the long term, that kind of relieving the pressure from the glam will be very protective for the podocyte, and these patients will do much better over the long term comparing to the patients who have a supernormal GFR or hyperfiltration. So a lot of trials that we're not going to go through all the trials, that proves that ACE and ARBs are kind of good for patients with kidney disease. It applies both to diabetic and non-diabetic, mainly proteinuric compared to non-proteinuria. But a lot of them will have an impact of kidney function decline, time to dialysis, and of course mortality benefit as well. Now with 3-4 years, there's a lot of emphasis on actually Sgl2 inhibitors to protect the kidney with and without diabetes. And there's a lot of trials. We participated in a lot of trials. I was one of the PIs in the Creatine trials here in UTESCA. So Sgl2 is your a medication that you need to use in patients with CKD. But pay attention to all of these trials. They added Sgl2 on top of, a maximum tolerated ACE or ARB. So you start with ACE and ARB, you maximize your therapy, and then if you have room with Sgl2, you add Sgl2 for renal protection. And I see a lot of you guys are using a lot of Sgl2 in our patients, and that's wonderful to see. So putting the physiology into clinical practice and what happens in the clinical setting, this is what happens in the clinical situation. So this is one of the trials, the EMPA trial, where they looked at the EMPA in diabetes patients, and they compare it to placebo on a background of ACE or ARB. I forgot which one. I think it's a mix of both. But you can notice here when you start Sgl2, there's actually a dip in the eGFR when you start, and that kind of stabilize and maybe improve a little bit. And if you notice here, if you have a patient without Sgl2, the GFR initially is much better, but look here, if you follow them down the road, the patient on Sgl2 remains stable with the eGFR. There's a dip, but they remain stable. But patients without Sgl2, you see a steady decline in the eGFR, and the eGFR slope is much worse in these patients. The same thing apply for ACE inhibitors. You're going to have this dip as well. So don't get worried if you have a dip in the GFR rise in the creatinine initially. This is expected. Actually, some people think that if you don't get a dip in the creatinine, in the eGFR, or increase in the creatinine, you're not achieving this reduction in the intragranular pressure. Maybe you're not achieving this renal protection. So please don't get worried about this kind of increase in the creatinine. I would not ignore it. I would watch the patients and make sure that, it's kind of becomes steady or stable. And roughly 20%, 25% with both ACE and SGLT2 is acceptable from where you start. So what's the trend in angiotensin II converting enzyme inhibitors and ARBs use in these patients with impaired kidney function? If you look from the 90s to kind of the last 2010 or so, there has been a steady increase, but we really plateaued since then in terms of the use of ACE and ARB in these patients. And a lot of time I see people kind of taking the shortcut in terms of blood pressure management in these patients. In ACE and ARB, you have to worry about creatinine going up. You have to worry about hyperkalemia. You have to worry about a lot of things. So some people will just take the a shortcut and do amlodipine or nifedipine. So we shouldn't do that. We should have a lot of emphasis on starting patients on ACE and ARB, and hopefully SGLT2 if they can tolerate it as well. And hopefully all of our patients need to be on ACE and ARB and SGLT2 if they can tolerate it, and if there is no side effect from these medications. Of course, you have to worry about eGFR with SGLT2. Right now we're not using it for GFR below kind of 30 or 25. With ACE and ARB, very commonly we're getting hyperkalemia, but with the introduction of the potassium binders, this could be a way of kind of introducing more ACE and ARB for these patients. Glycemic control is important in our patients who have diabetic nephropathy, but at the same time, be careful with too much glycemic control, especially if you have a patients with limited life expectancy, hypoglycemia, they're more incidence of hypoglycemia, and especially in the advanced CKD as well, you have to worry about these medications. A lot of them are actually renally dosed. So if you have a patients who have already a lot of comorbidities and short life expectancy, targeting a higher A1C might be acceptable for these patients. I want to also bring a very important point to the group, that the kidney is really important in gluconeogenesis and glucose handling. A lot of people think that gluconeogenesis mainly happens in the liver, but actually if you compare a gram per gram kidney tissue versus a liver tissue, actually the kidney produces more sugar compared to the liver, but the kidney size is really small. So very often you're going to see patients with a chronic kidney disease, when they progress, their diabetes is getting better. This is not because they're doing a better job, or they're more compliant or watching their diet. A lot of time these patients just have a progressive kidney disease, so they don't clear the insulin really well. So the insulin kind of hangs a little bit more. They don't have a lot of gluconeogenesis that happens in the kidney, so you have less gluconeogenesis. So you see an A1C of kind of 6 or 7, and the patient thinks that, oh, they're getting better. But sometimes a better A1C might indicate a worse kidney function. And that also applies and is an important factor when you see patients with advanced kidney disease. You see an A1C of 6 or 7, you think, how come this is diabetic nephropathy? This A1C probably has been in the 14 range for many years, and since the kidney is progressing and getting worse, now the A1C is getting better because of the worse kidney function. So I talked about you might guys see using Bicitra or sodium bicarb, or mainly sodium bicarb and Bicitra that we use. And you wonder why. There are a lot of reasons. Metabolic acidosis is not really good to have, of course, a lot of bone disease. But beside that, the main reason why we focus on a correction of metabolic acidosis is actually there is good evidence to suggest that maintaining a bicarb above 22 can actually slow the progression of CKD. So they took 3 groups of patients: usual care, patients on bicarb therapy or alkali therapy, sodium bicarb or Bicitra, and the third group is fruit and vegetables. And they looked at the EGFR slope, and you can see that the usual care without correcting the bicarb above 22, the slope is really steep, and there is significant worsening in the EGFR. While patients with alkali therapy or fruit and vegetables, the slope of the EGFR decline is actually much better. And the reason why fruit and vegetables are good, because a lot of fruit and vegetables are actually accompanied by citrate, and citrate is kind of an alkali. So for kidney disease, I think eating fruit and vegetables can be a little bit tricky because of the potassium. But in general, if the potassium is not an issue, like a lot of berries and have a lot of citrate, so that can actually slow down the progression. Or you can give sodium bicarb or Bicitra for these patients, or even a plain baking soda can do the trick as well. So blood pressure, we talked about mainly focusing on the ACE and ARB for these patients for renal protection. But at the same time, we also need to use the appropriate diuretic therapy. We can start with thiazide for a GFR, above 45 or 50, but once the GFR is less than 30, you really have to use loop diuretic. And please never give Lasix once a day. Once a day Lasix is not going to work well, or Bumix for the patients, because it's from the physiology standpoint that if you only give once a day Lasix, that a lot of kind of downstream channels might be upregulated and actually lead to more sodium absorption after the Lasix effect kind of weans off. And that's why a lot of time you see us using metalazone or in the inpatient setting, mainly to kind of block this kind of upregulation. Dr. Kunau, he was one of the famous nephrologists here. He retired 4 or 5 years ago, and I was one of his fellows. He used to say once a day Lasix is actually the work of devil. So don't use Lasix once a day, at least twice a day. So if you use Lasix and for volume control, or thiazide for blood pressure control and volume control, what would you do if the creatinine increases? To be honest with you, I wouldn't do anything. A lot of time I see people stopping the Lasix and torsemide or thiazide because they think the patient is having an AKI. This actually could be a normal expected consequences of hemoconcentration. The baseline that you were seeing when the patient having a 2+ edema or 3+ edema, maybe not a true baseline, and the baseline is actually is this true baseline that you're seeing right now after good volume control. I would not ignore that rise in the creatinine, but I would not stop the medication to prevent AKI, or thinking that diuretics are nephrotoxic. Diuretics are not nephrotoxic. They're only nephrotoxic if you create a state of volume depletion or if you suspect AIN. Beside that, diuretics are not nephrotoxic. Don't have much time to kind of go over this in details, but you might see us guys using a lot of torsemide. Torsemide is a much better pill. It's 1-to-1 from IV to PO. It's much better bioavailable, and you can use it once a day, and I would not mind that because the duration of action is much longer. While Lasix, you should not use it once a day. Some people think that it might have actually more protective effect on the heart and cardiac remodeling. So torsemide is, and that's why we're using a lot of torsemide in our patients population if you see these patients. Whenever you think about kind of blood pressure combination in patients with CKD, try to kind of put this figure in your mind and use a good combination for the patients. For a patient with CKD, you'll start with ACE and ARB, add an Sgl2, then maybe kind of add the calcium channel blocker or beta blocker or diuretic if the patient is volume up. But sometimes I see this kind of weird combination of kind of hydralazine and nifedipine and minoxidil, and it's all vasodilator. Why we're using these kind of combination? I think you have to tackle multiple axes of the blood pressure for better blood pressure control. So try to kind of use different medications with different mechanism of action rather than just different names. I'm not going to go over this. This is kind of mainly our what we do when we see the patients in the clinic. So to give more time for questions, so just for a few seconds about appropriate renal dosing of the medication, we really need to pay attention to the renal dosing. I don't remember that I go always to up to date. There's a section for each EGFR. So just be careful with the renal dosing. Very commonly, people forget that metformin is renally dosed. I see CKD 4-5 with metformin being on. That's a malpractice kind of wait to happen if the patient went with lactic acidosis to the ICU. I see a lot of fenofibrate for whatever reason being used in patients with mild hypertriglyceridemia. And it's very tricky that fenofibrate can increase your creatinine, although it's not nephrotoxic, but it kind of makes the picture a little bit muddy. And fenofibrate doesn't have really a lot of role in hyperlipidemia management unless you have extreme hypertriglyceridemia. A lot of gabapentin, baclofen with neurotoxicity. So just pay attention to these patients, and when you prescribe the medications and antibiotics, and use the appropriate and refer to UpToDate or whatever app you're using. So if you guys remember that patient that we presented initially, I started the patients on losartan for renal protection, brought the patient back in 4 weeks. Creatinine went up to 1.2. Blood pressure was better, but still high. UPC improved from 3.5 grams to 2 grams. So I was happy, but still needed some work. So I added Sgl2 inhibitor for renal protection and glycemic control. Came after 4 weeks. Creatinine went up again to 1.4. Blood pressure is better, but now the patient is eating a lot of salt and sodium and with 2+ edema. The proteinuria is slightly better, but I'm not happy about this edema and volume control and the blood pressure. So I added hydrochlorothiazide since this is an early CKD and we can use thiazide. The patient came back in 8 weeks. The creatinine went up to 1.6 and the blood pressure now is normal. The patient doesn't have edema. The patient feels great. And the UPC went down from 1 to 1.1. So we started with the creatinine of 1. I ended up with a creatinine of 1.6. We started with a proteinuria of 3.5. We ended up with a proteinuria of less than 200 milligram. This patient is going to do much, much better than a patient with a creatinine of 1 and a proteinuria of 4 grams, despite this increase in the creatinine from 1 to 1.6. So for this patient, please don't stop the medication and think that this is an AKI and you're doing the wrong thing. You're doing the right thing, and this patient is going to do much better over the long term. And you probably saved him dialysis over the long term. I'm sorry if I did not give enough time for questions, but I'll be happy to take any questions.
Do we have anybody with any questions?
Hi, Dr. Nassar. I have 2 quick questions.
Sure.
Do you prefer hydrochlorothiazide over chlorthalidone for patients like you presented earlier today?
Second question, I think it's the same. The chlorthalidone is a little bit longer acting, so it might actually last more than 24 hours. It's all the same. Even when we use it for diuresis in the inpatient setting with like metolazone, sometimes you can use anyone, to be honest with you. Actually, indapamide might have a better kind of profile from the side effect, like the hyperglycemia, hyperlipidemia, and other things. But I think overall, they're the same.
Okay, thanks. My second question is contrast agents. Are you, I mean, there are some thoughts that's not really backed up by evidence, or
yeah, there's a lot of debate about this. When contrast agents, I think the question, if you need this kind of CT scan with contrast, and you're doing it for a specific reason, just go ahead and do it. I don't think I would delay kind of a CAT scan that's to look for PE or a PCI or something because you're worried about contrast. I think you should go ahead and do it. if there's an alternative, probably I would use the alternative, but there's a lot of debate in the nephrology community whether actually there is a toxicity or there's not toxicity. I agree with you.
Okay, thank you.
You're welcome.
You have
Any
any
more
other?
questions?
I didn't see any questions come in through the chat. I did for everybody if you could, and I'll send it out in an email here later today, but if we could make sure that we provide some feedback for Dr. Nassar. Anybody else want to comment or have a question?
Thank you so much. That was a very helpful presentation.
Thank you. Okay, well, you guys have a good day.
Okay, with that, thank you everybody so much. Thank you, Dr. Nassar, for presenting to us today. Hope everybody has a great day.
Thank you. You too. Bye-bye.